Hello, my name is Sheriff Youssef. I'm a fifth year resident in internal medicine at the University of Toronto. I'm presenting you the findings of my pilot study on simulation-based medical education. From here on, it will be abbreviated as SBME. The study was approved by the Research Ethics Board at the University of Toronto. I have no disclosures to declare. So for a little bit of background, SBME for postgraduate internal medicine training has been developing in Canada over the past several years. The main focus of SBME has been on ACLS procedures and more lately point of care ultrasound or POCUS. Despite these developments, SBME is not yet standardized across Canada, and trainee experiences may be variable, and the effectiveness of SBME is not entirely known. So the purpose of the study was to explore some of the perceptions of Canadian internal medicine postgraduate trainees on SBME. To do this, I developed a survey addressing three main content domains, which included the first being SBME training adequacy, the second being sense of preparedness, um, the third and lastly being feedback, supervision, and competency by design implementation using entrustable professional activities assessments or EPA assessments. 80 residents were invited and 18 completed the survey. 3 of the residents were enrolled in year 1, 9 were enrolled in year 2, 6 were enrolled in year 3. Going over to the results, on average, trainees led anywhere from 1 to 5 cardiac arrests per month and performed anywhere from 1 to 5 procedures per month. SBAB training from feedback of the survey based on both formal and informal sessions seemed to be 1 to 2 sessions per year on average. These results are all summarized in Table 1. There were 3 main findings from the study overall, as illustrated in figures 2 and 3 and 4. The first main finding is that we can see that more than half of the participating trainees felt their current SBME was inadequate and insufficient training to prepare them to lead cardiac arrests and perform procedures. These findings don't necessarily suggest that SBME is ineffective. Rather, since residents seem to be receiving few SBME sessions per year, it could be that SBME opportunities for trainees in internal medicine are still limited. We know from prior research that the combination of both simulation and also deliberate practice significantly improve trainee performance and mastery learning, particularly in providing advanced cardiovascular life support or ACLS and even performing procedures. The second finding, as well as illustrated in figure 4, is we can see that most trainees actually agreed that SBME allowed for routine supervision and feedback from designated supervisors. When it comes to leading cardiac arrest teams, most trainees felt more supervised with an 82.4% agreement, and most trainees agreed that they received more routine feedback with 64.7% agreement in the simulated setting compared with the clinical setting. And these differences between those two settings was actually statistically significant. Um, these findings seem to be congruent with a prior national survey of Canadian residents, which found that internal medicine residents received minimal supervision from designated supervisors when leading cardiac arrest teams. So it would make sense that a lack of supervision can potentially lead to fewer opportunities for feedback and assessment. And lastly, my last finding was as well illustrated in figure 4, is we can see that trainees agreed that they routinely received supervision, feedback, and EPAs in both the clinical and simulated settings when it comes to performing procedures. And there were no statistically significant differences between these trends. I bring these findings to light because I actually think that these highlight the current role of competency-based medical education implementation, and particularly in this case, in mastery learning. And this has been proposed previously in prior studies. The main limitation of the study is the small sample size and the response rate. These aspects limit the overall reliability and accuracy of the findings. However, some of these limitations will be addressed and overcome when more complete data from trainee participants and input from simulation lead experts at Canadian institutions becomes available. This is the end of my presentation. I would like to take any questions. And lastly, I would like to acknowledge the contributions of Dr. Natalie Bandrock, Dr. Luke Devine, and Dr. Jillian Spiegel for reviewing the content of the survey. Thank you for listening.